Is it treatable? I mean, what options are available? Can you get back the original function, or is it something that you just can sort of improve on?
You talk about women feeling that they're invisible in midlife, and I actually wanted to be. It was almost like I became a completely different person.
Women's sexual health is not well researched, a bit of a taboo. We probably don't understand it as well as we should.
So what sort of motivated you to sort of talk about it? Was it
blind rage? Absolute blind rage. Had no idea what was going on. And there's also, in my opinion, a slight kind of toxic positivity, especially in social media. In a response to that, the things that I've found that have been helpful, which I kind of call kind of life hacks, really, most of them are completely free.
The updated NICE guideline, it's good to see that it focuses on kind of personalised information. It's never too late. There's always something that can be done.
Hi everyone, and welcome to the second instalment of the JFPR Breaking the Silence Health Panel discussions. I'm Juliet Francis, and I'm the founder and director of JFPR. At a time where your health issue may take longer to diagnose due to NHS waiting lists, or you're struggling to find the right pathway with your GP, our health discussions offer a deep dive into some of the most common conditions or shed a light on symptoms that are underrepresented. Our second discussion focuses on the menopause and the pelvic floor. According to the Royal College of Obstetrics and Gynaecology, new data reveals that over 60% of UK women have at least one symptom of poor pelvic floor health, and of those, 69% of sufferers have not spoken to anyone in the NHS about their pelvic floor health. Of these, 39% thought their symptoms were normal and 21% were too embarrassed. So, we have two special guests joining us today. We have Elizabeth Joseph, writer and menopause advocate, and urogynaecologist, Miss Rhiannon Bray of New Victoria Hospital based in Kingston, Surrey. Guys, really great to have you both today. Thank you so much for joining. We shall start by finding out a little bit more about the pelvic floor. Rhiannon is a consultant obstetrician and gynaecologist with a specialism in urogynecology at Kingston Hospital NHS Trust. She qualified from Guy's, King's and St Thomas Medical School and completed subspecialist training in urogynecology at Imperial College NHS Healthcare Trust. She's experienced in the medical and surgical management of urinary incontinence and vaginal prolapse and other disorders of the pelvic floor. So Rhiannon, I'll address the first couple of questions to you. Could you tell me what the difference is between a gynaecologist and a urogynaecologist?
Yes, so a urogynaecologist is a gynaecologist who's got additional training that enables them to focus on treating things such as prolapse, incontinence, or any pelvic floor disorders.
Okay. What are the symptoms of pelvic floor dysfunction and what are the main causes?
There's a variety of symptoms, as I mentioned before, so prolapse, incontinence, or other bladder issues such as urgency, frequency, and other things that you might not necessarily associate with pelvic floor dysfunction, such as urinary tract infections, are quite common. And diagnosis is based principally actually on symptoms. So a woman might notice that she's having urinary urgency, frequency. With prolapse, you might get the sensation that something's coming down, and then traditionally you would see a urogynaecologist and have an examination. So often on examination we may see prolapse, which is where the walls of the vagina or the uterus can come down. And interestingly, lots of women may have prolapse and actually not be symptomatic of it, and these urinary symptoms and bowel symptoms can happen independently of prolapse, but often they will come together. And there's a variety of tests that we can do to get a bit more information. But rather than for diagnosis, they're actually often to sort of guide treatments, so to help us decide which pathway we might go down for treatments, surgical treatments or a variety of conservative treatments, like physiotherapy and things like that.
How is it normally diagnosed, actually? I mean, what sort of tests do you do?
So an examination, and with examination, you'll see if something's coming down. So I will examine women while they're lying flat, but often that might not represent their symptoms. So I'll ask women to lie on their side so we can get a look at the front and back walls of the vagina more easily. Or often, if I'm not seeing what I might expect to fit with the patient's symptoms, I'll ask them to stand up. So sometimes it's a bit off-putting for patients, but I'll actually examine someone when they're standing up, do a vaginal examination to really get a good idea of what's happening with the pelvic floor on a day-to-day basis. we know that symptoms are worse at the end of the day, or when women have been on their feet or doing lots of lifting and things. In women who are premenopausal, symptoms can also be worse in the second half of their cycle, where their estrogen levels are dropping, more similar to in the kind of perimenopausal, menopausal side. Time as well. On examination, if you go just by examination, they say probably 50% of UK women will have some degree of prolapse. So within urogynecology, it's actually really important based on symptoms. So if you have a prolapse and you don't feel that there's a lump or a bulge or something coming down, and you think your bladder and bowel function are normal for you, that's the definition of normal, is what you think is normal for you, then in a way it's kind of irrelevant, but it's once you get symptoms. So women will worry if they're examined and seen that they've got anatomical prolapse, but symptoms are important, more important.
Okay, that's really interesting. As I mentioned previously, my other special guest is writer and menopause advocate Elizabeth Joseph, aka the Menopause Guinea Pig. Elizabeth is also a pro-age model, speaker and author who advocates for breaking the stereotypes around menopause and women's health and well-being. And Liz's mission has built up an engaged following online and offers to create an open, opinion-free community for women going through the transition. So Liz, can you share your personal journey of the menopause and what you've actually encountered in terms of symptoms?
The thing for me was that I had no idea what perimenopause was, the build-up to menopause. So I was about 45 with young kids. And what felt like genuinely out of nowhere, I woke up one morning with kind of like a frozen shoulder feeling, which then basically came into to pain all down my right side and then sciatica all down my right leg. And I'm not exaggerating when I say this went on for 2 years and I had absolutely no idea what was going on. And I'm not one to suffer in silence. So I went back to the doctor repeatedly. I saw 2 physiotherapists, at everything, cranial osteopathy, musculoskeletal specialist, rheumatologist. I mean, I wasn't keeping quiet about it. And it got put down to stress. Then I started to experience brain fog, but I didn't know, I never heard that term. Just feelings of rage, anxiety, waking up with an impending sense of doom. So for like 2 years, having gone from being a very happy, positive, active person, and I genuinely thought I had some kind of sinister disease. I didn't understand until my period started to go a bit bonkers, at which point that was a change that I understood. So, I had to educate myself. I had to go online. I had to work it out. And that's when I learned for the first time, aged about 47, the word perimenopause. And then it just all completely made sense. But I genuinely thought I had an autoimmune disease because the aching was so bad. It would wake me up at night. And then the more you worry about it, the more you tense up, the worse you make it. So it really was. And I've read and heard numerous stories similar of women who thought they had, early onset dementia, thought they had autoimmune diseases. It's crazy. I think it's crazy.
It really is, actually. And that was kind of my second question is, how did it impact your sort of career and life? I mean, I'm sure that, in terms of work, it would have impacted your work because there's so many people at work, so many women I hear of and employers, who suddenly have a really very strong performing sort of woman, and at some point that, that sort of drops and they don't know what's happening. But yeah, I mean, I'm sure that it would have impacted your aspects of your life somehow.
You talk about women feeling that they're invisible in midlife, and I actually wanted to be. I went to work, did what I could, came home and closed the door. I stopped socializing. I stopped, even the thought getting on a train to go somewhere just terrified me. And it was almost like I became a completely different person. And I think a lot of women in that situation kind of detonate their lives. They leave partners, they leave jobs because they're trying to find an answer for why they feel the way they do. It's your hormones.
Completely. And it's really interesting how much of the body and mind it actually impacts. I mean, we're not just talking about bones here or, okay, we've actually now started to understand sort of mental health, but, just like hearing from Rhiannon about the pelvic floor and actually even going to the loo, like we think that actually, I don't know, you've done some funny exercise and you think that actually, you just haven't been able to get to the toilet properly because of that. Were any of the symptoms resonating with you that Rhiannon said?
So something else that people don't really talk about, but again, I've kind of researched and spoken to other women, is the whole disappearing orgasm thing. So when you've got your libido just goes, for some women, not all women, it's not the same for everybody, but your libido kind of goes off a cliff. But the other thing was the where did it go? Disappearing orgasms, which I think is linked to pelvic floor.
Yes,
Is that right?
Estrogen, the hormone that we're sort of declining during the menopause, does impact the blood flow to the tissues of the vulva and the vagina and the pelvic floor. So if there's less blood flow, then you can have less orgasmic potential. It's one of those use it or lose it things as well. And also, if you're going through all those stresses, your body doesn't feel like your own, your vagina's dry, sore, uncomfortable, and not sleeping well, then that's going to have a massive impact as well. It's probably an area that's actually sort of understudied. Women's sexual health is not well researched, not talked about, a bit of a taboo. And so there's, we probably don't understand it as well as we should.
I think it is. I really do think it is a taboo. It's one of the things I talk about when I give talks. I do kind of like 8 life hacks, natural life hacks to help with menopause. And one of them, the last one, I always say I'm going to end on a high. The last one is orgasms.
Yeah.
And I'm doing a talk, I won't say where, and I've been asked to not mention orgasms or sex because that's a bit too controversial.
Very interesting. I mean, you're talking about sort of, the whole body, the pelvic floor, separating sex and women almost like that's too much of a strong link. They don't want to actually dissociate. That's crazy, actually.
But I think we are a bit kind of, but don't like to talk about it openly.
Yeah.
No, it still is.
And is this because, you mentioned it was sort of estrogen dropping. Is that kind of the main link between pelvic floor health and, the menopause?
Yeah, in 2 ways. So estrogen can affect the skin or the epithelium, the tissue of the vagina. And with less estrogen, the tissues are kind of thin and delicate. There's less lubrication, so the skin's can feel dry, sore, uncomfortable. And that can then lead actually to urinary tract infections because it's easier for bacteria to travel into the bladder. And then also underneath the skin, we've got the muscles of the pelvic floor. So estrogen, with a low estrogen, the muscles can be thinner and weaker and don't work quite so well. So that's the main thing. Estrogen actually also has an effect on our microbiome. So we talk a lot about the gut microbiome, but actually there's a urobiome, which is the bacteria, viruses, fungi that live in the microbiome that live in the vagina. We know that estrogen encourages the good bacteria, so lactobacillus. So it's kind of a hit in every direction. It's hitting the tissues, the muscle, the microbiome. So,
what stage during the menopause do women tend to typically suffer from sort of poor pelvic floor health? Is it sort of perimenopause or is it just after the menopause?
Different aspects will have an effect. It can have anything can affect anyone at any point, but typically recurrent infections, urine infections, might occur quite early in the perimenopausal journey when women, as you found, not necessarily associating with menopause. They might be at an age, say, 42, 43, 47, where they're not expecting that it's menopause, but those declining levels of estrogen will make the tissues more prone to infection. So that's something that can present quite early. And then the other symptoms, such as prolapse, actually tends to take some time to develop. So the patients that I'll often see in my clinic at New Victoria, from a prolapse point of view, they're a few years after the menopause. Things are gradually declining over sort of 3 or 4 years, typically. Incontinence is a little bit in between. So some women sadly suffer with incontinence sort of ever since childbirth, basically, and it's been normalised and they just ignore it. And then it might get worse around perimenopause, or it might get much worse postmenopausal. So kind of any point in the journey, really, but it can be one of the first earlier clues of perimenopause.
And so is it treatable? What options are available? Can you get back the original function, or is it something that you just can sort of improve on?
Yeah, no, I think for prolapse, there's really good evidence for pelvic floor exercises. So we grade prolapse mild, moderate, severe, kind of depending on how low the bulge is coming in the vagina. There's evidence that 4 months of supervised pelvic floor exercises, so with a physiotherapist, not just being given a leaflet and told to go away and do your pelvic floor, can improve prolapse. So take it from severe to moderate or from moderate to mild. And then that will improve. Usually that will improve the patient's symptoms as well. So that's conservative measures. There's other things, looking at what you drink, when you drink, can have a huge impact on how the bladder functions. There are devices. I'm not sure if you've heard of something called a pessary, which can be usually as a ring shape that sits inside the vagina, can lift and support the pelvic floor. That can help with prolapse. Sometimes it can help with bladder function. Otherwise, there are surgeries. So there are operations usually done through the vagina that we can do to help and fix prolapse, kind of restore function.
Can I ask a question? I was really interested in what you drink and when you drink.
Yeah.
What's that?
So with bladder symptoms, so urgency or incontinence, we know that if you've got a more concentrated urine, it will actually irritate your bladder more. So women who've got urinary frequency often will try and decrease what they drink, because you can't be going to the toilet all the time, has a massive impact on your life. But a more concentrated urine will actually be more irritant and lead to women going more often. There's traditional kind of triggers for the bladder, like coffee, citrus, sadly alcohol, can irritate the bladder and make women go more often. So I see lots of women where actually sort of simple advice on what they're drinking. When is thinking about, if you drink in the evening, if you're drinking lots of water, or other drinks, caffeinated drinks at 6, 7, 8 o'clock in the evening, because that might be the only time you actually get to sit down and have a drink. But then that will affect you during the night. You're going to wake up and need to go for a wee. So there's so many sort of simple things that can make a big difference, actually.
So Liz, what motivated you to openly discuss, the menopause experience? I mean, it's only in the last few years that so many women have been able to openly discuss it. And since then, now we can hear it on the dinner table, it's fantastic. But I do wonder sometimes, what did our sort of parents do and our grandparents do, our maternal side, because they didn't have that open conversation, and there probably wasn't as many such, medical team to sort of support them during that time. So what sort of motivated you to sort of talk about it? Was it
blind rage? Absolute blind rage that, as I said before, for 2 years had no idea what was going on. And it was like completely surrounded by a deafening wall of silence. And I think you're right. Now, we talk about, so-and-so in the menopause space and menopause this and, products that slap the word menopause on them. It's become this huge, huge thing. I feel women have gone from being completely ignored to being seen as a huge demographic. And it's, buy this and you need this and you need to do the other. But it literally just 7 years ago, I mean, never mind parents' generation and grandparents' generation, I'd never heard the word perimenopause, and I was furious. I was absolutely furious that nobody had warned me, that nobody had put these really bizarre symptoms together for me. So now you see great big lists where, burnt tongue, again, estrogen and the lack of natural oils and, but they make no sense. They made no sense. So rage, absolute rage. And I was determined, in my small way, that nobody should go through that again. It's one thing, yes, you've got all these symptoms and they're not great, but when you have no idea what they are, I just think I think it's terrifying. And you were talking before about, in the workplace, people just in the middle of a presentation forgetting the name of something and then starting to sweat and then getting nervous. It's not okay.
So Liz, have you sort of found any particular strategies or products that have actually helped you during the transition of the menopause?
Well, I've tried hundreds, so I can write about them and talk about them. And as I was saying earlier, I think, we were ignored, and now we're a huge demographic with lots of money. And there's an awful lot of scaremongering that goes on in the press, that, it's dreadful and you must do this and you must do that. And there's also, in my opinion, a slight kind of toxic positivity, especially in social media, from people who are trying to sell you things. So you should be doing this and you should be doing this. And if you're not doing this, you're really not trying hard enough. And kind of in a response to that, the things that I've found that have been helpful, which I kind of call kind of life hacks, really, most of them are completely free. So my absolute favourite, which is the most difficult thing to do ever and is completely free, is cold water therapy.
Oh,
Now,
yeah.
so I wouldn't love to throw myself in the sea. I don't like going in the sea, and I live close to the sea. So what I do is I turn the shower down at the end of the shower, slowly, 1, 2, 3, completely freezing cold, and start counting on my head, back of my shoulders, etc. And I can only manage about 60 seconds now, but it positively impacts genuinely all of your symptoms. You know, one of the things, itchy skin, it calms down your skin, it calms down your mood, it lessens inflammation in your body. It's like hugely a game changer, but it's brutal and it never gets any easier. And then the other thing, is meditation and mindfulness, right? And people tend to go, okay, I'm a busy woman, I haven't got time to be sitting in my Zen garden, meditating for half an hour. But with the sciatica and the frozen shoulder and everything I mentioned before, part of that was I was so stressed that I was literally holding myself together. And I was causing it, or I was making it worse by clenching. Like, I had this weird thing where if I'm stressed, I clench my right buttock, which was creating this pain. So I feel it now when I turn the water to cold, this clenches. So this is clearly my stress response. And it's just becoming more aware of your own body. So literally just checking in every now and then. And I bet, anyone listening will suddenly go, oh, yeah, relax your shoulders. Because we all do it. We all tense in different ways. So it's things like that, becoming more mindful, which is easy to say and less difficult to do. And also hugely diet. It was recommended to me a long time ago to go for a more Mediterranean style diet, and kind of autoimmune, anti-inflammatory. Yeah. I always get that wrong. An anti-inflammatory diet, which again calms everything down. That's made a huge difference. And hugely depressingly, the biggest change that's made the biggest difference. But again, we're just passing through. So lots of women on Instagram in their 60s and 70s have said, oh, I can drink now, don't worry about it. But if I have even one glass now, I just sweat all night. Yeah, hugely. Yeah.
Wine can be quite inflammatory, actually, sadly.
Yeah, so it's anything that really calms that down, isn't it?
Yeah.
Calms down the kind of inflammatory nature of it all. And you're adding to your stress, because I think I'm right in saying that estrogen, one of its many things it did was kind of calm down the cortisol, calm down the kind of adrenaline. And that's why you can find yourself just being full of rage or just being really, really tense. So any of these, allegedly woo-woo things, like the cold water swimming, it's just calming everything down. So whatever works for you. You don't have to do Pilates if you don't like it. You don't have to do strength training. You can just go for a walk. You can spend that half-hour break you get at work just wandering around the block.
Interesting you said about diet. Did you find that any of the, you heard of like phytoestrogens and soy and things, did that help?
It didn't seem to make any difference, but I think it's a really good question, because just because it doesn't work for me, and I say that so many times, doesn't mean it won't work for someone else. And lots of people have tried all of that. Yeah. But also I had a food intolerance test recently, and yeast is a big no-no for me. So I should stay away from all of those things. So I think it's finding what works for you. Yeah. Again, lots of people saying you should do this and you should do that. If it doesn't work for you, you absolutely shouldn't. Yeah. But I think it's finding what gives you a bit of peace.
That fits actually with the updated NICE guideline. It's good to see that it focuses on kind of personalised information, even when talking about risk, looking at your other risk factors and actually tailoring the pros and cons of things like HRT to your own risk profile, or seeing us as individuals rather than one thing fits all, because we know that just doesn't work.
So the NICE guidelines are basically trying to make sure that each woman has a bespoke sort of treatment plan.
Yeah, that is probably a change. So there was a guideline, I think it was in 2015, and it's being updated at the moment, so it's not out yet. But it's nice to see that it does talk about personalised information and looking at women's individual risk factors when talking about risk or HRT or other treatments. So kind of entering this era of personalised medicine.
And what about the suggestion that CPT might be a really good sort of treatment option for women? I think that's probably one of the most controversial treatments on as a suggestion. What did you think of that, actually?
So yeah, interesting that you say it's controversial. So to me, it makes sense that from what you've been saying and what we know about stress and just the fact that you're going through this huge change, all these different symptoms, is going to be stressful. So if you can address that stress, then obviously I feel as though everything would be better. And I think it's not suggesting it instead of HRT. There's absolutely a place for HRT for lots of women, but as an addition, or some women may choose that they don't want HRT. So I think it's a good option.
I think that's a really good point. That it isn't one or the other. It isn't, I do everything natural, so I'm against HRT, or, one or the other. It's like if you were going to run a marathon, you wouldn't just buy a nice pair of trainers and take some vitamins. You would look at your whole lifestyle, and I think all of these things can complement, and it doesn't have to be seen as, I don't want that, it's something to help me. It's, if it doesn't work for you, that's fine, but it's to go alongside it. Yeah, that's really important.
Yeah, stress is we're not good enough at studying actually the effect of stress on the body. I suppose it's difficult to study, but stress affects your physiology and that affects everything. So finding a way to manage that, and nice that if there are ways without drugs and medicine, it's helpful.
I think this could probably apply to both of you, because you both have like a community that follow you about menopause, but and particularly the pelvic floor. But are there any misconceptions that you've come across in terms of sort of pelvic floor health?
I suppose, sort of as we mentioned earlier, that incontinence is normal. It's to be expected. I think that is a big misconception. Incontinence or bladder problems, urgency and frequency, is common, but it's not normal. So if women are suffering, then they really should seek help, and actually to not be afraid, because there's lots of things that, there was this whole mesh debate, and mesh was used as a surgical treatment for stress incontinence. And I think that scared a lot of women and made them not want to come forward to ask for help, because they're afraid they'll end up in having an operation that may not be the best thing for them. But actually there's lots of conservative things like physiotherapy that can be done. So yeah, the misconception is that incontinence is normal and that there's nothing you can do about it. Both of those things are totally wrong.
Really massive babies, and I was told by a friend who was a doctor, because I hadn't bothered to do any of my pelvic floor exercises when I was pregnant. She was like, well, it's too late, you can't undo the damage. And I met her at an antenatal class, we were both, and she said, there's no point trying to do them now,
Is there a point that it can be too late?
No, I mean, yes, it's good to start. We think it's good to start in pregnancy as prevention. In medicine, prevention is paramount, but no, it's never too late. There's always something that can be done. I mean, I don't think in my 15 years career that there's anyone, very few patients where we've had to say there's nothing we can do. And by the time we've got to that point, we've done loads and their quality of life is so much improved. So no, there is plenty can be done.
Can you discuss also the importance of community and the support network sort of around women? I mean, how important it is?
I think it's fundamental. So again, back to my years of deafening wall of silence, and I would try and bring up, perimenopause or different symptoms.
Question: when you were going through some of these symptoms, and you were going to testosterone therapy, etc., did you already have an idea that it could be the perimenopause before you actually went to see a doctor? At which point did you actually know? Well,
I did not until my periods went crazy. I remember going to see, is it a sports masseuse, you call it, doing sports massage. And I became quite good friends with this lady because she was determined to work out what was going on with me. We were both the same age. And I remember talking about stuff that was going on for her in the house. And then I started feeling these drips on me, and she was crying because of the stress that she was under. And this makes me want to cry. Looking back, she was going through perimenopause. I was going through perimenopause. We couldn't help each other because neither of us knew. No, I had no idea. And I went to the doctor with all these weird symptoms that now you see on lists. Here are the 46 symptoms. I had no idea at all. And I would bring things up at, kids' birthday parties or waiting at the school gates, and it was nothing at all. And as I started to work out what it was, then I started to try and talk, and it would be like a tumbleweed moment. I think menopause certainly then was very much linked to aging. So you weren't necessarily going to even admit that it could be that for you. It was when I went on Instagram, and there's a certain distance, isn't there? It's not an anonymity because you're putting yourself on there, but that was a revelation because people were honest and helping each other. And I would literally put on, I've got this, and this, any suggestions? And it would just be this community of women, try this. And I think it's hugely, hugely important. And now I'm more confident to just start talking about it. And I've noticed a shift that people are willing to go, yeah, I've got dreadful night sweats, and have a good laugh about it and make a few suggestions. So I think it's key.
Yeah, I think that's one of the misconceptions, is that your periods kind of become irregular or your periods stop and then you get menopause. Yeah. But it can happen, your symptoms can be 5-6 years actually before that. Or it can actually be that your periods get heavier, not that they're more spaced out. So that's a big misconception. I think probably, as you're saying, is starting to change now. But even 5-6 years ago, that was strongly held belief probably by the public.
So, Rhiannon, just explain as well, also, obviously with, related to menopause symptoms, you can always tell that the pelvic floor has had some sort of dysfunction as a result of that. But what if there's something more sinister? There's been a couple of stories in the press recently about somebody being sort of diagnosed with, menopausal symptoms, and it actually turned out to be cancerous. I mean, is there a way to differentiate the two, just in case?
Yeah, so it's tricky because menopause can have such a variety of symptoms and they can fit with other things. I think the best advice really is, as a woman, you do tend to know your own body. So these stories in the media, when you read it, the woman would say, that didn't quite fit for me. That didn't seem like the right diagnosis. So just, if it doesn't fit for you, then going back to your healthcare provider, or if that person doesn't listen to you, going somewhere else where someone will listen to you is important. Then treatments should help. So if you're starting HRT or you're trying other treatments and you're not getting any better, then again, you need to go back. Either that's not the right treatment for you, or yes, rarely it could be something else. So yeah, it can be tricky, but very possible to pick up if something else is going on, and just listening to your body and going back and asking again.
Yeah, not being fobbed off.
Yeah.
Not being fobbed off. A number of women have been told, oh, you're just depressed, or it's just that. And you're right, you are the expert in yourself. And don't suffer in silence either.
Yeah.
Yeah, I mean, that is a good point. I mean, obviously you're a gynecologist, so you've got specific sort of training and you understand exactly what's going on.
Yeah.
But, other specialists probably don't have that level of training, and, people are getting referred to those specialists and then sort of being sort of sidestepped because, they're not even being explained to what those symptoms are sort of related to.
It's difficult because the GP is probably at the front line, and there are some GPs who are amazingly knowledgeable about menopause, probably more knowledgeable than a lot of gynecologists. So yeah, it's seeing someone, and actually that's what's mentioned in the NICE guidelines as well, seeing someone who's got an expertise in menopause, because it can be, when it's straightforward, but a lot of the time it's not. And seeing someone with specialist knowledge is really important.
You've already sort of mentioned this actually, Liz, but Rhiannon, I mean, I don't know whether diet and nutrition is something that you advise or sort of support with some of your patients when it comes to, for example, vaginal atrophy or anything like that?
Yeah, so I think the mainstay within urogynecology is actually supplementing with estrogen. So we'll use estrogen cream or tablets. And the main thing to know about that is actually very little is systemically absorbed. So it's very, very safe, to the point where it's now available over the counter. But we'll offer. Yeah. So
Really?
Yeah, there's a vaginal estrogen pessary, so a little tablet that goes in the vagina that you can buy over the counter. I think you have to have a conversation with the pharmacist, but women can access it easily, so that's been a big recent change, but it's also something that your GP can prescribe very easily and put on a repeat prescription, so you shouldn't need to go and purchase it. So yes, estrogen makes a big difference. Estrogen encourages lactobacillus, which is one of the good bacteria, so sometimes we will suggest probiotics, probiotic supplements. Now, they're not as well researched as medicine, so as a doctor I'm probably more inclined to recommend medications, but it makes sense that some of the probiotics can be helpful. You probably know more about sort of diet and eating, so we might suggest phytoestrogens could be helpful for some women. And yeah, eating the rainbow and thinking about your microbiome to just support your tissues as well. Protein, I think, really important for women as we get older to eat enough protein. I think just traditionally women don't eat enough protein to just maintain your muscle mass, and that's just as important for the pelvic floor as everywhere else. Keeping your muscles will decrease your frailty, which will help you to live longer, and your pelvic floor to be better as well. So there is lots that we can do, and thinking about it sooner. So we were talking a bit about prevention. These are things that you want to be doing from midlife, really, in preparation for
Your diet, and not in a way that's kind of making life more difficult, but looking to maybe I'll start Pilates in my 40s rather than when I really need it in my 30s. Definitely. And strength training.
Yeah, love strength training.
Good for your bones.
Yeah,
not being fobbed off.
Yeah,
not being fobbed off. A number of women who've been told, oh, you're just depressed, or it's just that, and you're right, you are the expert in yourself, and don't suffer in silence either.
Yeah.
And there's a bit of a growing trend about sort of homeopathic treatments actually on TikTok for menopause. Have you tried it with things like that?
I've just tried all manner of things, but it's funny you should say that, because I was interviewing a lady who was an HRT specialist, and she said to me, there's an awful lot of nonsense on social media about magnesium. All these people are saying that they should take magnesium, and there are no studies, there are no scientific studies to show whether this is actually the case. And she said, women come to me and they say, it really worked for 3 months and now it doesn't work and it's just a placebo. And at the time I thought, well, do you know what? If it is just a placebo, so what? If I feel something's working for me, so, if somebody tries a homeopathic remedy, as long as they're not doing something that makes them poorly, as long as they're not doing something that is detrimental. If you feel you're being proactive and you're taking control, and if, taking magnesium glycinate half an hour before I go to bed makes me think I'm having a better night's sleep, do you know what? I am having a better night's sleep because I'm calmed down, because I think it works. So I think, again, it's a balance, and it's to do with the individual. If you feel it works for you, if it's helping, then that's great. You don't need to be sort of telling everyone else they have to be doing that. But, maybe there isn't enough research because enough research hasn't been done. Not that it doesn't work, for example. So I've certainly, in terms of magnesium, lots of people have told me that it's made a huge difference.
Physiologically.
I think we've come to the end. So our final question. So Liz, what's your hopes for the future of sort of menopause discussion, both offline and online? What do you hope for in the future? What are you campaigning for, actually?
Just that it carries on. So I think the big thing that Rhiannon and I were chatting before, and I was like, in the past, women have always had opinions that they've shared with me, whether I wanted them or not, in terms of, you should be breastfeeding, you should be doing this, you shouldn't be doing that. And I haven't loved all of it. But I hated stumbling into perimenopause completely clueless. So I think, now we're all talking about it, just keep talking about it. We're not going to agree. There are going to be those who are like, it's only HRT, there's those, it should only be natural. We always disagree in that way. I just love hearing it talked about, and I just want it to carry on. I think it's wonderful.
And actually, in terms of specifically about pelvic floor health, what's some of the sort of ideals that you feel that people should know about? I mean, it's definitely one of the underrepresented symptoms.
Yeah, so just empowering women to come forward, seek help. There's lots that can be done, not normalising these absolutely not. And so, as I said, it's common, not normal, but they should come and see a specialist, see a urogynaecologist. Ideally in medicine, we'd be looking at kind of prevention. So once there's a problem, it's more difficult to treat, but can we actually get in there before there's problems, would be the best way forward.
Especially with the statistic of 60% of women will actually experience,
Yeah, so common. 1 in 10 women will have a surgery actually for prolapse over their lifetime. So something that we should be talking about.
Each other.
Yeah, yeah.
I think that's the big thing, is that we're letting it be taboo. We should be telling each other, we should be saying, try this, or do you know that this happens, rather than being too embarrassed to talk about it.
Yeah.
It's a huge...
And it's starting, the process is starting, so hopefully we'll just sort of continue and see more and more conversations being so much more open and less taboo. I think you've got a question, haven't you, from one of your followers that you want to ask?
Oh, well, it was 2 things. So one was the classic, why do I pee a bit when I sneeze, and what can I do to stop that happening?
Yeah, so I suppose, yeah, that's a classic kind of symptom of pelvic floor, usually weakness, or what can happen is there's damage during childbirth or pregnancy, but when we're young and fit and our muscles are strong, we can make up for that. But as we age or go through menopause and the muscles get weaker, then symptoms kind of reveal themselves. So yeah, the biggest thing actually is pelvic floor exercises, but seeing a physiotherapist who teaches you how to do them properly. So lots of women will think they're doing their pelvic floor, but actually they're pushing down or they're over tensing. The pelvic floor is quite complex and it needs to contract and relax in the right way. So seeing a physiotherapist to be examined and actually have a proper technique can make a really big difference. So yeah, that's probably the best starting.
It's good. That kind of answers my second question,
Yeah.
which was how do you know you're doing them properly?
Yeah,
So
I think you don't.
Yeah,
You really don't unless you see a physio or someone with expertise in that area and they examine you. And
Okay.
yeah,
And then you can get, once you know what you're doing, you can get the NHS squeezy app, can't you? Because the thing is, even if you know how to do them, is remembering to do them, because you can literally do them at the bus stop, can't you?
yeah, exactly.
So the app kind of reminds you to do your exercises.
Good. It's an NHS app called Squeezy. It's got a timer on it that sort of guides you through doing the pelvic floor exercise. My patients have told me it's got an alarm that will just go off and off and off until you do them, and it's very irritating, but that can kind of make you do it. So yeah, there's lots of hacks, but yeah, again, easier said than done. And so just sometimes that sort of, mentorship of having a physio, the accountability. You see someone, so we've got great physios at the New Victoria, where they'll see a woman and then they know that they're going back. So you've got your homework, you do your pelvic floor. It makes a big difference.
Thank you, guys. That was really insightful. Unfortunately, I think that's all we have time for today. But thank you to our special guest, Liz, for your contribution towards this really interesting and very much needed discussion. And thank you to our consultant, Miss Rhiannon Bray, from the New Victoria Hospital, for shedding light on the condition. Until next time, take care.